Good afternoon and good evening. I'm Sanyal Schulten, Deputy Head of HCV Access here at FIND, the Foundation for Innovative New Diagnostics. And I'm here to welcome you today to our session at COLDA. Before I begin, I would like to thank very much the organizers of COLDA for giving us this chance to speak with you today. Today, we'll be talking about how diagnostic innovations can catalyze service delivery scale-up for hepatitis C. So a little bit about FIND. FIND, we are a global nonprofit driving diagnostic innovation to combat major diseases affecting the world's poorest populations. We have offices in Vietnam, India, Kenya, South Africa, and Geneva. We are a WHO collaborating center for laboratory strengthening and diagnostic technology evaluation. We are a WHO SAGE in vitro diagnostic member, and we are ISO 13485 quality management system certified for IVD clinical trials. Currently at FIND, we work on 6 disease areas: antimicrobial resistance, hepatitis and HIV, malaria and fever, neglected tropical diseases, pandemic preparedness, which certainly is including COVID, and tuberculosis. So what we do is we address market failures by partnering to develop end-to-end diagnostic solutions to, for, and with low and middle income countries. So to move to hepatitis and hepatitis C, why are we speaking it? What is the need to drive diagnostic scale-up and innovation? Well, the need is that there are around 71 million people living with hepatitis C today. And of those 71 million, in 2016, less than 15 million were diagnosed. Now, if we are to reach the WHO 2030 target for elimination of 90% of those infected diagnosed, we have a lot of people to diagnose in the next 10 years. So what we can see here is that the major gaps, less than 80% undiagnosed in 2016, and then an even smaller amount of that started on treatment. Now, I'd like to just point out here, the colored bars are by WHO region, and you will see that the red region is the Eastern Mediterranean. A large number of infected, a large number of those diagnosed, and again, started on treatment and cured. And you may hear about this in other presentations throughout COLDA, but this is driven mainly by Egypt's national response towards elimination, as they have made a huge and fantastic effort towards hepatitis C elimination. Now, just a reminder on the algorithm for hepatitis C. It's a multi-step process. This is the WHO HCV testing guidelines, and as you can see, first you need to have a serological test, and this can either be an ELISA or a quality assured rapid diagnostic test. Now, if you are antibody positive, then you can go to the second step, which is HCV RNA or HCV core antigen testing for confirmation of viremia. Afterwards, then it requires a liver staging, then treat all with pangenotypic, and lastly, a test of cure, which is called SVR12. So this is an HCV RNA test 12 weeks post completion of treatment. So what do we need to do? We know that we have a large number of people who are living with hepatitis C who have not been diagnosed. Well, we need to find the missing millions, we need to link them to care, and we need to do this in a cost-efficient manner. The cost-efficient manner is important. In any disease program, cost efficiency is important. And with hepatitis, it's even more so. This is because there are not large global funding bodies to help countries address hepatitis C as there are maybe for some other diseases. So when countries do take on the mandate to scale up service delivery and to strive for hepatitis C elimination, they will be doing so paying out of their own pocket. Therefore, understanding the ways to provide service delivery in the most cost-efficient or cost-saving manner is very important. So how can we do it? Well, we can look at decentralized or risk-based screening at places where people already go for care, with reflex testing for RNA and liver staging, and decentralized treatment. Now, what are some of the tools that we could use to help us on this journey? Well, FIND has been working through our Head Start program, which is hepatitis C elimination through access to diagnostics, which is funded by UNITAID, to work on various aspects to address this. The first thing we're doing is the research and development. So we're working to catalyze the pipeline for new and innovative HCV diagnostic technologies. We're also working within countries to understand how to best have these pilot projects and studies catalyze a larger national and regional hepatitis C service delivery response, HCV market forecasting, and evidence sharing. So today we're going to be talking about the research and development portion of the portfolio. Specifically today, we are going to be talking about dried blood spot for a hepatitis C RNA. Now, our portfolio is much wider than that. So just to briefly say, we're working on HCV molecular point of care technologies. This ranges from the expert finger stick cartridge to evaluating gene drive and intended settings of use, to optimizing and evaluating the hepatitis C assay for the point of care technology MoBio. We're also working on various ways to improve serological screening technologies. This has ranged from a study that comprised of an evaluation of 13 different RDTs in a variety of different samples, including HIV, HCV co-infected, as well as our work on hepatitis C self-testing. So this is looking at the feasibility and acceptability of hepatitis C self-testing using both an oral fluid prototype and a blood-based prototype, as well as diagnostic accuracy, cost-effectiveness analysis, and values and preferences. Now, the DBS, and so I will let our two esteemed speakers speak more about the DBS, but just quickly to say that we looked at validating manufacturer protocols for hepatitis C RNA DBS, as well as manufacturer protocol for hepatitis C ELISA. And we are also looking at the hepatitis C core antigen technologies, particularly understanding the developments and bringing forward the development of a novel core antigen rapid diagnostic test. Another way to look at our pipeline. Now, we kind of have a mantra of simplification, decentralization, and integration. And these are how all of our portfolios fit across that mantra. We wanted to highlight DBS with you today because it does offer abilities to simplify the diagnostic algorithm, allow decentralization of the sample collection at primary healthcare, and allow integration of both using the same machines that may already exist for HIV viral load to do the HCV viral load, as well as integrating in the sample transport mechanism. So potentially hepatitis C DBS could be using the same sample transport networks already established for things such as HIV viral load DBS. So my pleasure to introduce our two speakers today. So first will be Professor Claude, who is a professor of clinical microbiology at the College of Medicine and Health Sciences, University of Rwanda, and he's one of our co-PIs for our DBS study in Rwanda. He will speak about the preliminary results from the study. It's a multi-country study, and he's going to focus on the results from Rwanda. And then second, we have Dr. Janvier, and he is head of STI and bloodborne infection at Rwanda Biomedical Center. And so he'll speak with us about some thoughts and considerations of how hepatitis C DBS could be useful in even further advancing the response to hepatitis C elimination. So I would like to thank all of our Head Start partners and our collaborators. A special thanks for our participants who enrolled in our trials and studies, and thanks very much to you all for attending our session today. Thank you.
Thank you very much for giving me the opportunity to present on behalf of collaborators for this multi-center clinical evaluation to assess the performance of centralized assays for hepatitis B, C viruses RNA detection from dried blood spot samples. So we're going to present this preliminary study on behalf, preliminary results on behalf of other PIs for this project. Next. So as a as a background, I think we do know that there are major gaps in the area of HIV/HCV testing. As we know all that this process is too complex, made of two steps, where we first have to do a screening using antibody testing. And once antibody testing is positive, I think we need to also confirm by doing HSV viral loads. As a result of this complex process, we have seen some report that says that 80% of cases are diagnosed in 2016. And we know that currently hepatitis C viral load is done through a centralized process where HCV plasma viral load is done in a centralized lab. And this kind of testing is really associated with challenges like in most of the low and middle income settings where we do have a very weak sample transportation network, and also there are limited resources for preparing plasma, where we found no centrifuge and other many challenges which are due to this plasma being performed in the central lab. But I think this centralized HCV plasma viral load still offers some opportunities where there is a chance or a way to really have all the tests of disease like hepatitis B, HIV to be integrated, and it's also offer some economy of scales where we have the opportunity to perform a high volume of tests. And I think DBS offer a very good solutions as by using this dyed blood spots DBS in place of the plasma seem to be allow decentralization of sample collections, and this DBS specimen can be collected from finger prick and also from venous blood. And we do know that there is no cold chain requirement for preparing DBS, and also the use of DBS has been seen to really reduce the cost associated with the diagnosis of hepatitis C. And these DBS samples can also be used for testing for antibodies to screen for HCV, and also it can be used also for RNA testing and also genotyping, although some of the DAs do not require the use of genotype in some settings. And DBS HCV RNA testing has been reported to be accurate in many previous research, with a pooled sensitivity around 98%, and also a specificity of 89%. But of course, those previous studies has some shortcomings in the sense that most of the platforms that were used in those evaluations were in-house and also commercial method, and also there were no really a good standardization of DBS procedures during those studies, and most of those DBS samples were prepared in the lab and some of the times kept frozen, so that we could not really assess the stability of DBS at room temperature. So there were very limited data on the stability of DBS at room temperature. And that's why, with the support of fund, this project was designed to really complement literature in giving some report to evaluate the diagnostic performance of HCV viral load from DBS specimen, which were collected via finger prick and also phlebotomy to compare to the Abbott plasma HCV viral load. We also wanted to also evaluate the diagnostic performance of HCV viral load from DBS and plasma suppression card specimen against the same assays using those plus Roche and Roche 4800 and also Ologis plasma HCV viral load. And for this study, the central laboratory, which is actually the National Reference Laboratory in Australia, we also wanted to evaluate the performance of 3 centralized HCV viral assays from plasma specimen against the performance of Roche Cobas 6,800 HCV viral assays. But for this presentation, we'll be focused on the first objective to evaluate the diagnostic performance of HCV viral load from DBS specimen collected via fingerprint and also phlebotomy compared to the Abbott plasma HCV viral load. And this study is currently performed at many sites in many countries. So we have in Greece, Hellenic Scientific Society for Study of AIDS and Sexual Transmitted Disease, which is implementing this study. And in Cameroon, the Centre Pasteur of Cameroon is implementing this study. And also in Georgia, we have the National Center of Disease of Control and Public Health implementing the project. And in Rwanda, the project is implemented by Rwanda Military Hospital in Kigali, capital. And our main lab, where we ship samples for other comparisons, is actually the National Reference Laboratory in Australia, Melbourne. During this evaluation, many platforms are under use, and for the for example, in Cameroon, Georgia, Greece, in Rwanda, we use the Abbott M2000 RT DBS platform for DBS, and also the same platform is also used for plasma in NLL Australia. And the Roche Cobas 6800 for plasma separation card and DBS is used in Australia and NLL Australia. And also the same times also the Roche Cobas 4800 is used for plasma separation card in Australia. And also Logis USA is also used in Australia on the DBS. So those are the different platforms that we are using in this project. As far as the study populations, we have participants who were enrolled in Cameroon, Georgia, and Greece, and Rwanda, as I mentioned before. And all individuals who have reached the age of adult, as defined by the country-specific regulations, are able, and also who are able to understand the scope of the study to the informed consent, will be enrolled in this population, in this study. And we do have 3 different population groups who were included in the study. So the first, we included all individuals with positive antibody, anti-HCV antibodies. And some of the group also were made of patients or individuals who are at risk of HCV, and also some of the population were also a group of patients or individuals exposed to HCV treatment. For the sample workflow, I think we started by screening of the participants, and once screening is done, the participant is provided with informed consent. And we had different type of sample which were collected during this project. The DBS which were collected from the capillary blood and also from ADTA. As you can see on this flow, we did have a number of 6 DBS cards which were collected from the capillary blood, and 1 plasma separation card which was also collected from the capillary blood. And among those specimen, we use one of the DBS collected for Abbott to do for the Abbott viral load, and also we had some of the DBS and also 1 plasma special card stored and shipped weekly to the central lab. As far as for the venous blood, we prepared 11 DBS from the venous blood, and also 3 plasma cards from this venous blood. And those we had 1 DBS prepared from this venous blood. We have 1 blood DBS on which we use Abbott to really perform the viral load on this blood DBS. Other DBS and also plasma separation card were also shipped 2 weekly to the central lab. And also we also prepare plasma from the venous blood, which we allocate in different aliquots, and some aliquots were also either tested for Abbott M2000 for viral load, and also others were shipped central lab after every 1 month. And one plasma also was also subject to genotype at the site of the study. In all, in Cameroon, the lab technicians were performing the sample collections, but in Georgia and Rwanda, we had nurses collecting the samples, while in Greece, doctors were involved in the sample collections. As far as the result of this evaluation, this project, I think we have seen that overall, the majority of our participants were male, but if you see in Cameroon and in Rwanda, we still do not see differences in terms of the sex. And we had also different population groups, as I mentioned in my introductions, where we have majority of the population is made of participants who are HCV seropositive. As preliminary result, when you compare the abort DBS capillary blood to plasma on abort, we observed that there were some variability in the results across all the sites, but the overall performance of this evaluation of the DBS compared to plasma was high, with a pooled sensitivity of 95%. And if you see the specificity, we have seen that we also see the same variability across the site, but the overall performance was very high also, with a pooled specificity of 97%. If you see in Rwanda, for example, we do have a specificity of 100% when compared DBS capillary blood to plasma on Abbott platform. And when you compare the Abbott, the DBS venous blood compared to plasma on the same platform Abbott, we observe a similar result in terms of sensitivity around 95 and also specificity of 97, which were obtained with the DBS prepared from ADTA whole blood, which actually demonstrates that this sample equivalence is rare between capillary blood and also venous blood in DBS. And when we compare our performance, the performance of Abbott DBS by population group, we observed that the performance of DBS among the HCV seropositive and also HCV risk group was very high, but the sensitivity among patients exposed to DAs was markedly reduced to 77% when using the limit detection of the Abbott assay, which is actually around 12 international units per ml. And if you see, we had 88 samples where the DBS could not really give an accurate result of the amount of viral load. And we know that the limit of detection for the Abbott DBS is around 462 international units per ml. And as per the European Association for the Liver, Study of the Liver guidelines, in low and middle income settings, we recommend qualitative assays with a low limit detection of below 1,000 international units per ml, which can also be really very important and be used to assess the virological response in this case. And this response, as recommended by this society, should be assessed at week 24 post-treatment. So we still see the use of DBS as very important in assessing the response to the treatment. So as a discussion, we have seen that there was some variability in the result of sensitivity between sites, which might actually reflect the inherent variability of DBS as a sample type. We have also observed a very high specificity observed in a DAA experienced individual, which actually confirmed that the DBS can be safely used to confirm the cure. And also whether DBS can be used in lieu of plasma for sustained viral response after 12 weeks to identify treatment failure with low level of viremia still require further analysis to establish whether the cutoff for 1,000 can be clinically sufficient. And finally, this study confirmed that the overall performance of DBS was very high, either collected through a finger prick or spotting ADTA venous blood into filter paper. compared to the plasma as our gold standards. As we have seen, the sensitivity was 95% compared to 98% full sensitivity, which is published in meta-analysis. And also for the same for specificity, where we found a very similar specificity of 97 when compared to other published meta-analyses. So with this, I would like to thank the funders for this study, the INITAID, for funding this study, and also thanks the technical support of the FIND team in implementing this project, and also other PIs from different sites involved in this project, and also the Minister of Health, and also other Abbott and Roche Diagnostics. Thank you very much.
Hello, everyone. I'm going to present on the consideration for the use of drought blind spot samples for the HCV viral testing in Rwanda. I'm Dr. Janvier Serumondo, the Director of Sexually Transmitted Infections and Other Blood-Borne Infections Unit in Rwanda Biomedical Center. I'm going to start by a quick background on Rwanda viral hepatitis management. The hepatitis program was created in 2011 by the Ministry of Health, followed by the creation of the National Technical Working Group in 2012, the development of national guidelines for hepatitis management in 2013, the screening and treatment of first patients in 2015, the testing, the mass screening campaigns in 2017, and finally the launch of HCV elimination plan in 2018. The elimination plan for HCV aimed to screen 4 million people to treat around 110 people during 5 years. Following the launch of that elimination plan, many initiatives were put in place, including the introduction of rapid diagnostic tests, the mass screening, which were intensified, the price reduction for tests and medicines, but also the task shifting from doctors to nurses, and the decentralization of hepatitis management services from high level to the lower level health facilities. So far, 3,900,000 people have been screened for HCV and 25,000 have been treated. This photo shows the demand and awareness raised among the population of Rwanda. It was a session of mass screening for hepatitis B and C in the southern province of Rwanda in 2017. You can see that this mass population was present at the screening site, and it shows that the awareness is raised among the population. Regarding the task shifting, we have trained more than 1,500 healthcare providers, including 225 doctors, 1,210 nurses, 588 lab techs, and 43 data managers to help for HCV elimination. Then the task shifting has followed by the decentralization of services from high-level health facilities to the lower-level health facilities. You can see on this map the red spots, which represent the health centers where the hepatitis services are currently provided. It shows that the geographical accessibility of the service has been improved. Coming back to the main point of this presentation, the DBS used for HCV viral testing. Let's see some advantages and some disadvantages. Advantages: DBS specimens are easier to collect, store, and transport than plasma samples. They can be collected through finger prick, avoiding phlebotomy and centrifugation. They can be stored and shipped at the ambient temperature, eliminating the need for cold chain transport, centrifugation, frozen shipment, or high train staff. DBS specimens, once dried, are not considered biohazardous. The viral load using DBS specimens has a relatively low cost of consumables, logistics, and overall testing method compared to the viral load using plasma specimens. Therefore, DBS can greatly simplify storage and transport to a reference laboratory from remote sites, and thus can overcome the lack of laboratory capacity in resource-limited settings. Some disadvantages include the increased laboratory staff time required for testing and a relatively low accuracy compared to the standard plasma viral load, but depending on the DBS method. As a conclusion, based on the highlighted multiple advantages of the DBS technique, managers and technical personnel have to analyze the possibility to use the DBS viral testing at a large scale for testing not only HCV, but also HIV and HBV viral load samples. There is a hope that the ongoing studies comparing the HCV viral load using DBS and plasma-based specimens being conducted in collaboration with FIND will provide guidance and recommendations for the use of DBS method in HCV viral load testing. I would like to acknowledge the government of Rwanda through the Ministry of Health, the national and international organizations, partners, pharmaceutical companies, and individuals for the support provided to Rwanda hepatitis program so far. Thank you very much.